So what's this video covering? Today we're talking about the newly released Medicare payment policy update, and this change is expected to impact a lot of Social Security beneficiaries, including retirees and disabled individuals, especially the major Title II groups connected to Medicare. Now with SSDI, standard disability benefits, there's that usual 24-month waiting period before Medicare eligibility kicks in. Once you qualify, boom, you're on Medicare. Retirement follows its own separate rules for enrollment, of course. But once people are covered, many are getting prescriptions, taking medications regularly, and overall things feel stable. Still, both you and I know something important here. Republicans often struggle when it comes to communicating policy effectively, even when parts of what they're saying are true. And what they're saying right now is something most people already recognize. A lot of Americans are over-medicated. A lot of people are selling prescriptions. A lot of individuals are handing off medications or using them in ways that were never intended by the prescribing physician, specialist, or primary care doctor. Most people know somebody selling pain pills. Most people know somebody involved in that world. Maybe you don't personally, but maybe you're just not closely connected to how things operate out there. I need you to really understand something here. Over the next 6 months, this may become one of the biggest direct policy shifts affecting veterans, disabled people, retirees, elderly Americans, and similar groups. Some of you may think, well, it's not that serious. Doctors getting paid to reduce prescriptions isn't a huge deal. And yes, in many cases it sounds reasonable, but it also has the potential to go very badly. Let me explain why. Under the May 2026 CMS billing guidance combined with the HHS Make America Healthy Again initiative, certain categories of people are far more likely to experience not an immediate cutoff, but a gradual reduction in how much medication they'll be allowed to receive moving forward. For many of you, medications are the thing holding daily life together. Without those prescriptions, your physical conditions, mental health issues, chronic pain, respiratory struggles, or cardiac problems could spiral completely out of control. Some people genuinely depend on pain meds, psych meds, heart medication, breathing treatments, or similar prescriptions just to function day to day. And the reality is this: these groups are probably going to experience what's called a deprescribing process. That means doctors slowly begin reducing medications over time. Group number 1 is children and adolescents. This category appears to be the main focus of the policy push. Kids taking psychiatric medications for ADHD, ADD, depression, anxiety, bipolar disorder, behavioral disorders, personality disorders, PTSD, and related conditions are especially targeted. Hold on a second, I've got papers all over my pocket here. Let me grab this. So what exactly does this mean? Under the updated framework, officials repeatedly emphasized and detailed concerns that these populations are overusing and misusing psychiatric medication. They also highlighted Medicaid and CHIP programs being encouraged to reduce these prescriptions. That matters because many SSI recipients rely on these programs. And remember, SSI includes elderly SSI, disabled SSI, and entrant SSI for immigrants. The reason I constantly repeat that in videos is because every time I mention immigrants qualifying for SSI, people flood the comments claiming immigrants cannot receive Social Security benefits. And honestly, at this point, I almost think some of them are trolling me on purpose. I know there are people online specifically hired to argue in comment sections from both political sides, but the fact remains, SSI absolutely includes benefits for poor elderly people, disabled individuals, and certain immigrants who reach qualifying immigration status. That's all under the Social Security umbrella. An immigrant can absolutely receive Social Security-related benefits after meeting specific immigration and naturalization standards. People get angry when I mention it, but it's true. A lot of politicians keep repeating the line that immigrants can never receive Social Security benefits. That's false. They can receive SSI entrant benefits under Title 16. It is administered through the Social Security Administration. Just look up Title 16 SSI entrant benefits. Please stop commenting that immigrants cannot receive Social Security. And while we're talking about misunderstandings, another thing driving me crazy is how many people still think Social Security only means retirement benefits. I love you guys, seriously, but that belief is completely wrong. Social Security includes an enormous number of programs. Retirement is the biggest one, yes, but it's far from the only one. Disability benefits, SSI, survivor benefits, widow benefits, spousal benefits, ex-spousal benefits, all of those fall under Social Security programs. Every single one. All right, stepping off the soapbox now. Some of you are probably asking why I sound irritated. I'm usually not this worked up, but tonight I kind of am. Feels like somebody lit the soapbox on fire underneath me. Anyway, moving on. Which groups are most likely to experience these medication reductions? Again, not always a total cutoff at first, but more of a gradual tapering process where medications are reduced over time. Group 1, heavily emphasized throughout the official documents, includes children and teenagers using psychiatric medications for ADHD, ADD, anxiety, depression, bipolar disorder, PTSD, behavioral conditions, and related mental impairments. And honestly, while the idea behind this may sound reasonable, politically it's probably going to explode in Republicans' faces. Because once you reduce medications for children who genuinely need them to function at school, participate in community activities, or even manage basic daily routines, some cases are going to go very badly. Without proper treatment, some of these kids become completely dysregulated. Out here on the farm, people might jokingly describe somebody acting completely out of control as feral. And that's what critics will point to. The Democrats are going to jump all over situations where a child loses access to medication, spirals badly, and then does something terrible. The headlines practically write themselves already. Look what happened after Republicans pushed medication reductions. That's exactly how this is going to be framed publicly. Next category, likely to face deprescribing efforts. Elderly Medicare patients over age 65 dealing with polypharmacy, basically retired people taking 5 or more medications, especially long-term psychiatric medications. Doctors are increasingly being encouraged to review these prescriptions and ask whether alternatives should be considered. And look, I know plenty of people on heavy psychiatric medication regimens. Some are friends, some are wonderful people, some I trust fully, others I trust only when they're consistently taking their meds. That's just reality. But if someone has been taking multiple psychiatric medications for years without adjustment, and newer treatment options now exist, doctors are likely going to start tapering old prescriptions while moving patients toward newer alternatives. Now let me be honest with you for a second. I've been involved in disability law far longer than I probably should have been. My own law firm is almost 13 years old, and before that I worked in disability law for other firms too. Honestly, I probably have an unhealthy relationship with Social Security law at this point. I'd love to trade some of this stress for more family time and actual evenings off, but life hasn't exactly lined up that way. And here's something I've learned. People who stay on psychiatric medication for 5 years or longer often never become exactly who they were before. The medication changes people. Sometimes that's good. Sometimes it stabilizes them. Sometimes it softens behaviors that were dangerous or chaotic. Other times it fundamentally alters personality traits. Whether the old version of that person was wonderful or terrible, it still changes them. I've also seen older adults slowly come off psychiatric medications after years of use. Usually it takes 3 to 4 years to detox and stabilize afterward. They're never exactly the same person they once were, but many gradually adjust. As people age, emotional extremes sometimes decrease. Anxiety fades for some people, while others instead drift toward emotional flatness or depression. These are simply patterns I've observed over time. Some people will hate hearing that, but it's true. You can dislike me for saying it, and I'll still care about you just the same. Now, Medicare has introduced new billing codes, CCM, PCM, BHI, COCM, that reimburse doctors for the time spent supervising medication, tapering, and deprescribing. In simpler terms, Medicare is now paying physicians to spend time figuring out why you should potentially receive less medication than before. Combine that with all the lawsuits over addictive painkillers, and suddenly you can see where this is going. For years, doctors prescribed huge quantities of pain medications that became highly addictive. Some patients genuinely need those medications permanently now because their bodies are dependent on them. But there's no denying that addiction, misuse, and prescription diversion became widespread. And if you think the prescription selling issue is exaggerated, I looked into the statistics myself. Adults taking 5 or more medications face roughly a 50% chance of dangerous drug interactions. Polypharmacy contributes to nearly 30% of hospital admissions among older adults. That means many retirees taking multiple medications end up hospitalized due to dangerous combinations inside the body. Among students prescribed ADHD stimulants, lifetime diversion rates reached 61.7%, the highest of any prescription category studied. Around 18.2% of individuals prescribed stimulants admitted diverting their medication within the past year, meaning selling it, giving it away, or otherwise misusing distribution. Studies involving nightlife and party scenes showed around 10.5% admitted selling prescription medications, while over 34% said someone had approached them asking to buy pills. And honestly, those numbers probably underreport reality, because who willingly admits selling prescriptions during a survey? The fact researchers even got that many admissions is kind of shocking. Among adults in addiction treatment programs, estimates suggested somewhere between 5% and 34% sold their prescribed medications. Personally, I suspect the actual numbers are higher. Most people know somebody involved in that behavior. Let's be real. When I was in law school, a huge number of students had stimulant dealers saved in their phones. They'd take study pills, stay awake until 4 in the morning, memorizing everything, then ace exams. Meanwhile, I had to do things the old-fashioned way: stress-eat hamburgers and study exhausted. Anyway, back to the main point. Children with mental health conditions, elderly patients taking multiple medications, and the next category, dementia patients and people with cognitive impairments. This includes individuals prescribed antipsychotics, benzodiazepines, antidepressants, and similar medications long-term. Studies show these populations often receive potentially inappropriate CNS active medications, and current guidance encourages deprescribing whenever improvement isn't clearly documented. Again, I actually think portions of this policy are reasonable. But politically, Republicans are going to take massive damage when the first tragedy occurs involving someone whose medications were reduced under these guidelines. Democrats will absolutely weaponize those cases publicly. Republicans historically struggle with messaging even when they believe they're implementing responsible reforms. Democrats, meanwhile, are incredibly skilled at framing emotional narratives. Next category likely to experience deprescribing efforts: long-term antidepressant users, especially people taking SSRIs like Prozac, Zoloft, or Lexapro. Doctors are likely to begin tapering plans for many of these patients because Medicare is now financially incentivizing the process. Doctors generally like treatment movement because active treatment generates billable work. Now, instead of simply prescribing medication indefinitely, they can also bill for reducing or replacing medications. And yes, some of the comments tonight are hilarious. Somebody said I'm attractive, while other people call me an ugly dwarf. For the record, I'm 5'9". That's average height. Somehow, everybody online decided 6 feet became average, which is definitely not true outside places like the Netherlands. Genetics gave me what genetics gave me. That's how it worked out. Back to the issue. Nursing home residents and long-term care patients are another heavily targeted category. Roughly half of nursing home residents take antidepressants. And honestly, if you're living in a nursing home, some level of depression is understandable. Some facilities are wonderful, but the really nice ones are usually extremely expensive. That's modern America for you. Luxury care exists if you can afford it. These nursing home populations often receive antidepressants, sedatives, and antipsychotics through Medicare coverage. They are highly likely to experience medication tapering efforts under these new reimbursement structures. Next group, long-term benzodiazepine users and stimulant users. Anxiety medications, insomnia medications, adult ADHD stimulants. These are considered high-risk categories due to dependence potential. And politically, this area may become especially explosive. If someone whose medication was tapered later commits a violent or disturbing act, the media reaction will be brutal. Schools, IEP programs, medical systems, and political parties will all end up dragged into the conversation. So from a healthcare analysis perspective, I understand the logic. Pay doctors for spending time evaluating whether medications remain appropriate. But from a political standpoint, I think this is going to become a major vulnerability for Republicans. Another affected category includes patients with single high-risk chronic conditions managed under PCM care models. These individuals often require frequent medication adjustments, especially pain management patients. Doctors are likely to rotate medications, taper older prescriptions, and transition people away from highly addictive narcotic-style treatments whenever possible. So let's summarize the major groups most likely targeted under these CMS care management code changes. Children and adolescents dealing with anxiety, depression, ADHD, PTSD, and behavioral conditions. Elderly Medicare patients over 65 taking multiple medications, people with dementia and cognitive impairments, long-term antidepressant users, especially SSRIs, nursing home and long-term care residents, long-term benzodiazepine and stimulant users, patients with chronic high-risk conditions involving complex medication management. Now, before we read through portions of the actual government document, which, by the way, uses ridiculously tiny font, I want to mention several important quotes. First, from Robert F. Kennedy Jr. regarding the MAHA initiative. Today, we take decisive action to address our nation's mental health crisis by confronting overuse of psychiatric medications, particularly among children. We will support patient autonomy, informed consent, shared decision-making, prevention, transparency, and more holistic mental health care. Now, what's important underneath that polished language is the broader policy direction connected to the Trump administration's approach. The emphasis is increasingly on treatment-first models for mentally unstable individuals rather than housing-first models. Instead of immediately prioritizing housing, the idea is institutional treatment first. Behavioral facilities, inpatient programs, supervised care, and then housing afterward if stability improves. Currently, what often happens is people deteriorate badly while homeless or unstable for years before finally receiving treatment and housing support. That's the messy reality. Another quote came from Dr. Joseph Goldberg of Mount Sinai, who described deprescribing as discontinuing treatments when the risks outweigh the benefits and replacing them with more effective alternatives. And honestly, one reason all of this is happening now is because a wave of newer psychiatric medications tailored more precisely to genetics and brain chemistry is expected over the next several years. Older medications like classic SSRIs may soon be viewed as outdated compared to newer targeted treatments. So part of this system is designed to financially motivate doctors to transition patients away from older medications that may not be producing meaningful improvement. Another physician commented that these billing codes are huge because they finally reimburse doctors for conversations about helping patients get off medications they've remained on for years. Healthcare analyst Stephen Brozak stated that America's mental health care system has avoided confronting psychiatric overprescribing for decades, and that the new HHS initiative attempts to finally address it through more holistic treatment approaches. Now remember, doctors technically could ignore all of this and continue prescribing medications normally, but the new billing structure creates financial incentives encouraging them to review and reduce medications. That changes behavior. Opposition voices also emerged. Dr. Teresa Rivera from the American Psychiatric Association argued that framing mental health primarily as an over-medication problem oversimplifies a much more complicated crisis. She emphasized that deprescribing alone is not enough. And honestly, she's correct. Current psychiatric medications often remain imperfect and inconsistent. If they worked dramatically better, far more mentally ill individuals would successfully return to work and stable functioning. Dr. Marketa Wills similarly argued that medicine faces both overprescribing and underprescribing problems simultaneously. That's also true. And let's be fair about something else. America has huge numbers of children and adults struggling with mental impairments. Some of that always existed historically, but communities handled it differently. Families concealed problems. Society functioned differently. Psychiatric medication culture didn't exist at today's scale. those social shifts matter too. Dr. Jonathan Alpert of Montefiore Medical Center emphasized that psychiatric medications can absolutely be life-saving, which is undeniably true. Some people genuinely would not survive without them. Another psychiatric expert argued the answer isn't stigmatizing medication, but ensuring patients receive individualized evidence-based care. Again, fair criticism. Now consider some numbers. Around 16.6% of American adults currently take antidepressants. Over 11% used prescription medication for depression in 2023 alone. SSRI use among children aged 3 to 17 more than doubled between 2006 and 2023. Stimulant use among young people reached over 5% in 2023, the highest rate among psychiatric medication classes for that age group. Psychotropic medication use among individuals aged 6 to 24 also increased dramatically over the past 2 decades. America is heavily medicated. That's simply reality. Now let's discuss the actual HHS document itself. The May 4, 2026 guidance describes supervised medication deprescribing as reducing or discontinuing medications when continued use may no longer provide meaningful clinical benefit. The government now formally recognizes deprescribing as part of active medical management. The document explains that physicians previously lacked clarity about how to bill Medicare for monitoring tapering processes between office visits. These new billing structures solve that issue. In other words, Medicare is now providing doctors with pathways to bill for evaluating whether medications should be reduced. The guidance specifically says deprescribing activities may include developing taper schedules, target doses, contingency planning, monitoring withdrawal symptoms, checking patient-reported symptoms electronically or by phone, coordinating care among multiple providers, adjusting taper schedules, and reviewing medication interactions. And honestly, I strongly suspect increased medication testing is coming too. Blood tests, urine tests, and monitoring systems to verify whether medications are actually being used appropriately. The document also confirms that pharmacists may participate in these deprescribing efforts under Medicare reimbursement systems. That surprised me. Pharmacists can now coordinate with physicians as part of billable medication management activities. I understand why policymakers believe that collaboration could help patients, but personally, I also see potential conflicts of interest and overreach. Pharmacists already act as gatekeepers for many pain medications. Expanding their role in medication reduction decisions could become problematic in some cases. The guidance further explains that clinicians are expected to use evidence-based tapering methods and individualized treatment plans rather than abrupt medication cutoffs. Behavioral health integration codes and psychiatric collaborative care management codes may also be used for monitoring tapering efforts involving SSRIs and similar medications. And honestly, reading through all of this, it really does feel like a systemic push toward reducing medication usage nationwide. Some people will absolutely benefit from safer prescribing practices. Others may experience destabilization if tapering occurs too aggressively. That's the concern. The document repeatedly emphasizes net clinical benefit. If patients are not showing measurable improvement, doctors are encouraged to reassess medications. But for disability recipients, that creates a complicated situation. If medications are working and improving functionality, Social Security may argue improvement exists. If medications are not improving functionality, doctors may justify tapering them. That creates a very difficult balancing act for many disabled individuals. So tomorrow's video is going to focus specifically on the criteria doctors may document when beginning the deprescribing process. The actual warning signs inside medical records indicating your medications may be tapered, switched, or reduced. That matters especially for younger patients, elderly individuals, disability recipients, and people dealing with conditions like schizophrenia, bipolar disorder, anxiety, ADHD, dementia, depression, PTSD, and related impairments. Because remember, if doctors document improvement from medications, Social Security could eventually review your case through a continuing disability review. So this entire issue becomes very important for SSI and SSDI recipients. All right, everybody, hopefully this breakdown helped. Please get some rest, enjoy your night, and try not to stress too much. Attorney Walter Knott, disability resolution law firm. Please remember to like, subscribe, become a member if you'd like,